Welcome back to the deep dive. Today, we are tackling what is, let's be honest, probably the highest stakes scenario we face in the emergency department. We're talking about the deteriorating patient, the one who is right on the edge of falling off that physiological cliff. And we're going to be focusing specifically on the core knowledge that every ED doctor and every ACCS trainee in the UK needs to have down cold. This is all about mastering that requirement, ACCS LO3 or SLO1. Our mission today is to cut through all the noise and give you the absolute essential strategies you need.
And that phrase you use, the physiological cliff, is just perfect. It's so important to set the scene with that. The body has this phenomenal ability to compensate. A patient can be in profound multi-system failure, but on the surface,
They can look okay.
deceptively stable. Their blood pressure might be holding up, their heart rate might not be too crazy. But the whole imperative for us in acute care is to see the failure before that compensation runs out. Because once they step over that edge, the decline is sudden, it's catastrophic, and, it's often irreversible. We have to read the subtitles, not just the headlines.
Okay, let's jump right in there. Starting with the tools we use on every single shift to try and flag these at-risk patients. Everyone in the NHS knows the National Early Warning Score, NEWS2. But how good is that red flag, really?
It's excellent for what it was designed for. It's a crucial trigger to get a clinician to the bedside, and it's fantastic for tracking trends over time.
So if you see it climbing from, say, a 3 to a 6,
You know you're losing ground. But, and this is the key thing, it is absolutely not a standalone diagnostic tool. You can't just wait for a high score to start worrying.
right, you can have a young, fit patient with raging sepsis who's compensating so well, their NEWS score is 0.
Exactly. They look fine until they're not.
So if NEWS2 can be a bit slow to the party, what's the faster, clearer marker that tells us if our resuscitation is actually working where it counts, at the cellular level?
It has to be serum lactate. That's the one. It takes us beyond just the simple hemodynamics. A lactate level is basically asking the question, are the tissues getting enough oxygen for normal metabolism? Or are they struggling?
So a rising lactate.
A rising lactate, or even one that just stubbornly refuses to come down while you're pouring fluids in, that's the clearest sign you can get of ongoing microvascular failure. It's telling you that your perfusion targets, your MAP, your heart rate, they might look okay on the monitor, but the cells are still starving. You're losing.
That's a really critical point. It's about fixing the tissue perfusion, not just chasing a blood pressure number. Okay, so let's pivot from recognition to action. The classic A to E assessment, but through that critical care lens that the ACCS curriculum demands.
Right. We're adapting it to preempt organ failure, not just react. So A for airway. The excellence point here is one word: anticipation. We see these patients all the time in ED. The post-extubal patient, the one with the worsening pneumonia, you can see them starting to tire.
And that's the moment.
That's the moment. A dropping GCS, difficulty clearing their secretions. You have to recognize that your window for a safe, controlled, rapid sequence induction is closing. That's when you make an immediate call to anesthetics or ICU. Waiting for stridor is managing a disaster, not a deterioration.
Okay, B for breathing. Getting the diagnosis right here seems to guide absolutely everything that comes next. We're talking about differentiating type 1 versus type 2 respiratory failure.
Absolutely. Type 1 is hypoxic failure.
No.
Low oxygen. Think of a classic pneumonia or pulmonary edema.
And type 2.
That's hypercapnic failure. They're retaining CO2. That's your severe asthmatic or your COPD exacerbation. And you can't just throw high-flow oxygen at a known CO2 retainer. That one decision point changes your entire management plan.
It dictates oxygenation versus ventilation.
Well, precisely. Which brings us to C for circulation. Your number one goal, standing in that resus bay, is to rapidly classify the shock state.
Is it distributive, like sepsis?
Or cardiogenic, so pump failure? Or hypovolemic from bleeding? Or even obstructive, like a massive PE or a tamponade.
If you skip that step,
you're just flying blind, chasing a blood pressure reading. And this is where POCUS, Point of Care Ultrasound, it's indispensable for us now in the UK ED.
Okay, I'm going to push back a bit here. Everyone loves POCUS, but in a chaotic resus with a crashing patient, isn't it more important to just get fluids in and drugs running than to start fiddling with an ultrasound probe?
It's a fair challenge, but I'd say no. POCUS is fast. And it guides that really delicate balancing act. You can look at the IVC, get an idea of fluid status, look at the heart's contractility. All in real time. All in seconds. And the excellence point is this. POCUS stops you doing massive harm. It stops you giving 2 liters of crystalloid to a patient whose heart is failing. A quick look shows you a barely moving ventricle, so you skip the aggressive fluids and go straight to vasopressors. That decision is fast and it's life-saving.
I'm sold. Okay, let's quickly tick off D&E. Disability beyond the GCS, what's the key thing?
It's the simple stuff that gets missed in the chaos. Strict control of blood sugar normoglycemia, and actively avoiding any fever in a patient with a suspected brain injury. Basic neuroprotection.
And E for exposure.
It's the non-negotiable command. Find the source, a full top-to-toe exam. You're looking for that hidden pressure sore, the abscess, the septic joint, the thing that's driving the whole collapse. If you don't look, you won't find it.
Right. We've recognized the problem. We've classified the shock. We've done our A to E. Now for the brass tacks. Actually starting organ support safely in the emergency department. Let's start with C, cardiovascular support. It begins with fluids, but the sources are clear. We have to be cautious here.
Very cautious. We're talking about a small, judicious fluid trial. Maybe 250 to 500 mils of a balanced crystalloid, like plasmolite or Hartmann's.
So this is not a blanket order for 2 liters.
No, it's a test. You're asking the question, is this patient fluid responsive?
And if they're not, if the hypotension persists,
Then you escalate, and you do it early. We're aiming to get that mean arterial pressure, the MAP, above 65 millimeters of mercury.
why that number specifically?
It's generally seen as the minimum pressure you need to keep the kidneys and the brain adequately perfused. Below that, and you're starving vital organs.
So we're starting vasopressors. What's the key safety point for ED staff doing this peripherally?
This is critical care 101, but in the resus room. If you're starting metaraminal or a dilute noradrenaline infusion, you must have a patent large bore cannula, and it has to be in a large proximal vein.
Not a little one in the back of the hand.
Absolutely not. And that site needs to be checked constantly for any sign of extravasation, because that can cause catastrophic tissue necrosis.
Right. Moving to B, respiratory support. Let's talk oxygen targets.
Generally, we're aiming for saturations of 94 to 98%, but the massive exception is for patients at risk of hypercapnic failure.
Our COPD patients.
Exactly. For them, it's a much tighter target, 88 to 92%. We don't want to switch off their hypoxic drive to breathe.
And for type 1 failure, high-flow nasal oxygen, HFNO, has become a real game changer. It's not just about the high oxygen concentration, is it?
Not at all, and that's a brilliant technical point that often gets missed. HFNO delivers a bit of PEEP, positive end expiratory pressure, which helps splint open the small airways.
Okay.
And crucially, it washes out all the anatomical dead space in your nose and throat. It basically makes your upper airway a much more efficient gas delivery system. It buys you precious time.
And then there's non-invasive ventilation, NIV.
Right, and you have to pick the right tool for the job. For acute cardiogenic pulmonary edema, it's CPAP continuous positive airway pressure. That reduces the work on the heart.
And for the COPD patient with a respiratory acidosis,
That's when you reach for BiPAP bilevel pressure. You need that difference in pressure to help them physically blow off the excess CO2.
the real excellence point here, though, is knowing when to give up on NIV.
Precisely. You have to recognize failure early. Is the patient getting agitated? Is there a massive air leak? And the big one, has their pH failed to improve after an hour?
If the answer is yes.
You must immediately start planning for a definitive airway. Continuing with failing NIV is just delaying the inevitable while the patient gets more and more exhausted. It's passive negligence.
Okay, finally, let's touch on renal protection. Acute kidney injury, AKI, is almost guaranteed in these sick patients.
It's an inevitable companion, yeah. So step 1 is mandatory monitoring. That means a urinary catheter for strict hourly fluid balance, no guessing.
Step 2 is perfusion.
Hit that MAP target of over 65. And step 3 is the one that sometimes gets forgotten in the heat of the moment. Stop all the nephrotoxic drugs.
So things like ACE inhibitors, NSAIs.
And antibiotics like gentamicin. They all need to be stopped immediately.
And what about managing the big, scary complication? Hyperkalemia.
Every ACCS trainee needs to have the sequence locked down cold. You see those tall, peaked T waves on the ECG?
First thing you reach for?
Intravenous calcium gluconate, that's for cardiac membrane stabilization. It protects the heart. Then immediately after, an insulin and dextrose infusion to actually shift the potassium back into the cells. That sequence has to be automatic.
Perfect. Okay, let's shift gears. We've covered the fundamentals of competence. Let's talk about what moves you into the realm of excellence, The advanced thinking, the team dynamics.
This is where all the nuance is, especially with fluids. We need to stop talking about fluid needs and start thinking about fluid responsiveness versus fluid tolerance.
That sounds a bit academic, but I can see how it would be incredibly practical.
It is. Just because a patient's stroke volume goes up when you give them a fluid bolus so they are responsive, that doesn't automatically mean they need more fluid.
So, the old teaching of if they respond, give more is outdated.
It's too simplistic. You have to ask, is there still concurrent clinical evidence of hypoperfusion? Is their lactate still high? Is their cap refill poor? If not, giving more fluid just risks harm.
You're talking about fluid overload.
Exactly. Pulmonary edema, gut edema. It's a huge cause of morbidity. You only give more fluid if they both respond to it. A&D still needed.
This brings me to a really interesting point. The patient who looks fine, the young, fit person compensating like mad,
Yeah.
how do we catch them before they collapse?
With a beautifully simple tool, the shock index.
Yes, I.
Yes. It's just the heart rate divided by the systolic blood pressure. It's the unsung hero of early shock detection.
Give us an example.
Okay, think of that young trauma patient. Their blood pressure is 110 systolic. Looks fine, but their heart rate is 100. Their shock index is 100 divided by 110, which is over 0.9.
And that's the trigger.
That is a massive red flag. An SI greater than 0.9 is a robust early indicator of significant shock, no matter what the new WS2 score says. It tells you this person is compensating hard and they are about to crash. So powerful. Okay, let's talk team dynamics. Leadership in a chaotic resus.
It's non-negotiable. And the first rule is closed-loop communication.
So I give an instruction.
And the team member repeats it back. You want 1 gram of ceftriaxone. Yes? Then, when it's done, they report back, ceftriaxone is in. It's simple, but it prevents so many errors.
It closes the loop.
It closes the loop. And building on that is the idea of a shared mental model. As the leader, you have to talk out loud. Verbalize the plan.
Even if it seems obvious.
Especially if it's obvious. Okay, team, this is a 65-year-old in septic shock. We've given 500 mils of fluid. We're starting metaraminol. Our target MAP is 65. Suddenly, everyone is on the exact same page.
And a final mark of real excellence in this area is knowing when to escalate and when to talk about the ceiling of care.
100%. You have to start those discussions early. With the patient, if possible, with their family, with the senior team. Excellence isn't just about aggressive resuscitation. It's also about recognizing when that's not appropriate or futile.
And when you do escalate, when you call ICU, use a structured handover. SBR is perfect for this. Situation, background, assessment, recommendation. That clarity avoids delay and gets the patient to definitive care, whether that's the ICU, the cath lab, or theater, as quickly as possible.
So bringing this all together, what does this mean for you, the ACCS trainee, on a busy shift in a UK ED? You've just walked through a gold standard, structured approach to mastering that core competency, ACCS LO 3, SLO 1.
And this isn't just theory. This is about generating evidence for your portfolio.
Exactly. If you follow this structured approach, especially explaining your rationale for fluid and vasopressor choices, well, that's a fantastic case-based discussion, a CBD right there.
Or you could get a consultant to observe you leading a resus using closed-loop communication. That's a perfect mini CEX.
Or even setting up and managing NIV safely in the day.
And don't forget written reflections, a challenging case where you had to establish a ceiling of care or had difficult communication with a family or another team that demonstrates real depth. And of course, use all the resources on RCEM learning. So, to leave you with one final provocative thought. If we know that managing organ dysfunction requires this much precision with fluid balance, with early markers like POCUS and lactate, then consider this. What systems can your team in your department implement today beyond just the mandated NEWS2 score to routinely calculate and flag up a shock index greater than 0.9? How can you catch that young compensating patient whose blood pressure right now looks deceptively normal? Because finding them, that's the difference between reacting to a collapse and truly preempting a disaster.